My name is Jennifer Lombardo. Thank you everybody for joining us today. I am the Community Relations Manager for Rothman Orthopedics. We normally do in-person lectures, but under the circumstances, obviously, we've been doing a lot of virtual lectures and they've been working out pretty well. So I hope everybody finds the content pretty interesting. Our lecture today will be given by Dr. Melody Hrubes. Dr. Hrubes is one of our non-operative sports medicine providers at Rothman. She's board certified in physical medicine and rehabilitation, as well as sports medicine, and is the director of our primary care sports division for our New York region. She serves as the medical director for the Radio City Rockettes, as a team physician for the United States Soccer Federation, and has previously worked with United States Gymnastics. Dr. Hrubes is going to be speaking today on My Knee Hurts, Why? Again, if anybody has any questions, there's a chat section at the bottom. So feel free to type your question in there, and then we will answer questions at the end. Or if you prefer, you can just unmute yourself and then ask the question out loud at the end of the lecture. Okay.
Go ahead and share my screen, Jen.
Yep. Just a reminder as well, if everybody can just keep your phone on mute, just so we don't have any disturbance during the lectures. And then again, if you have any questions afterwards.
Let's see here. Okay, so I love to talk about the knee because so many people have knee pain or knee problems, or maybe just knee twinges and you're not sure why. Thank you for putting your date of birth on your registration, because that's super helpful. We have people of all ages on today. I'm really happy to talk about problems that 20-year-olds have, problems that 80-year-olds have. So while we're going through the options, please think about your own knee, or maybe your friend's knee or a loved one's knee. Most people usually sign on because they have a question. If not, that's totally fine too. But please ask the questions when we get to the option for that. So when we talk about knee pain, why is usually the question that people ask, but when you follow up with a physician or a provider, you want to know where or how. That's kind of our first question. So when we think about where your knee hurts, we think about all the structures. So there are a ton of structures in your knee. Everybody knows about the bones. We have, Jen, can you see my arrow?
I can, yes.
Okay, perfect. So when we think about the knee joint, it's actually the end of your thigh and the top of your shin, and it takes the center of gravity from your pelvis and the ground reaction forces from your feet, and it kind of has to make everything work. So that's why when we think about the bones, we know we have the femur, the tibia, the fibula, as well as the kneecap or the patella. And then we think about the ligaments. So the ligaments provide the structure to the joint. And that's when you hear ACL, PCL, LCL over here, MCL. Those help structure the bones in place. And then we look at the muscles. We have the quadriceps, which is a bunch of muscles put together from the front. We have the back of the knee, which has the hamstrings and the gastrocs, and then a couple of other smaller muscles that kind of hold up the back. And then we also have the side of the knee, the outside, closer to your outside hip, and then the inside where the knees kind of touch. Both of those have different areas of tendons and bursa and other things that can hurt. So when somebody says their knee hurts, oftentimes instead of asking why, we ask where. What we're really looking for is what is hurting. And so that's why usually we'll say, we'll start pushing on you, we'll start pulling on things to see. So the other things that sometimes patients don't think about is we actually have a bunch of spaces in our knee. I think of these more as a victim area because they tend to not be the problem, but they hurt. And this can be a big reason why you finally say, I can't take it anymore, I have to go see somebody, something has to be done. You might have swelling. So the swelling in the back of your knee is a Baker's cyst. It's usually on the middle back, kind of next to your gastroc and hamstring on the inside. And as you can see, if you look in this bottom right image, the Baker's cyst is actually a continuation of your whole knee capsule. So when you have the knee capsule, we think about swelling more in the front of the knee, and that's when it can get really big. But you can see how swelling in the back of your knee can actually be pretty painful. It pushes on the tendons, it pushes on the muscles. It hurts when you bend your knee, when you try to flex your knee back. It can limit your range of motion. So these are all things that we think about. These aren't the only places that you can have fluid, though. If you look at these lighter blue areas here, these are all little pockets in your knee. If you look, they're kind of where you have areas of friction. So those can be places that can hurt and can swell, and we have to figure out why. So when we went through all those things, this is on my differential. So somebody comes in and they have knee pain, and I think, oh dear, okay, I have so many things to think about. And my mind starts racing. So that's why we ask you questions. That's why we say, when does it hurt? How does it hurt? What are you doing when it hurts? What makes it worse? What makes it better? Because that helps me narrow this crazy list down into something that is a little more accessible and I can focus. And sometimes I just have to do a bunch of tests to see what we can make hurt. And that's why sometimes we call them provocative maneuvers, because we're trying to provoke your pain, which seems kind of mean. But in reality, what we're trying to do is cause your pain so that we can treat the cause. We're talking about the front of your knee. A lot of people have front of the knee pain. And I usually ask, is it right underneath the kneecap? Is it deep? If it's right underneath the kneecap, we call it patellofemoral pain syndrome. And that's when it's not on top of the knee, but it's just deep to the kneecap. If you think about it, the kneecap actually floats on top of the femur. So when we're looking at that view, we know that there can be friction. And so the kneecap is actually floating between the patellar tendon and the quadriceps tendon, which can also be very painful, especially when you have tight muscles. So when we think about front of the knee pain, if this is an issue, then we have to address the cause. We need to work on strengthening. We need to work on how you bear weight, how you walk, how you run. When does it hurt? A lot of times people have pain in the front of their knee due to patellofemoral pain syndrome when they're going downstairs or when they're lunging or like deep squats, or if they've been sitting for a while. Those are usually signs of patellofemoral pain syndrome or a maltracking disorder. The side of the knee, the most common is this IT band. Because if you think about the IT band, it actually extends all the way past the hip up to your upper pelvis. So when people have pain on the side of their knee, I usually worry about the IT band first. Other things that can hurt, though, you see how this hamstring tendon also extends all the way down. It's more in the back a little bit, but it connects pretty close to where the IT band connects to the front. So it's just a matter of a few centimeters to see what is bothering you and where it hurts. Deep to that, though, you can see you have a meniscus. Your lateral meniscus can really bother you. Move a few things. I think that there is static when I'm touching the computer, so I'll try not to touch it as much. And then in the back of the knee, you can get swelling, like we talked about the Baker's cyst. And then there are a bunch of muscles and tendons that their job is to provide that powerful contraction to bend your knee, and then to also allow it to straighten in a controlled fashion. And that's with the popliteus, the plantaris, and you also get the hamstring muscles, which come down. You can see them come down on either side of the knee, or the gastroc, and that splits into two, and that comes up to the front of the knee. So everything kind of crosses together. So when people have pain, we have to figure out why. Also, when somebody has pain, we look at how. What causes it to hurt? What really bothers you? Is it truly pain, or is it something else? So stiffness can be a good indication of what's going on. Often osteoarthritis, which is, I call the privilege of getting older. So that's when we've started to wear away the cartilage, stiffness starts to occur. Morning stiffness that resolves in like half an hour or an hour tends to be osteoarthritis, or after you've been sitting for a while. Also, stiffness can be a general sign of an injury with inflammation. So if you hurt your knee and then you try to stand after a while, it might be tight. You have to almost feel like you have to stretch it out, and that can also be a cause of the stiffness. Swelling is a big problem. So swelling is also nonspecific. We don't ever just treat the swelling, we have to treat the cause of the swelling. Sometimes it's trauma, you fell, you banged your knee, you ran into something. That's fair. But sometimes it's due to something else, like gout can cause swelling of the knee. It can cause, there's also other types of crystal arthritis, not just gout, like pseudo gout or other types of arthritis that we would need to treat. Swelling can just be due to friction. The patella inside the patella as it's gliding along the femur. If you have a meniscus tear and you feel catching or clicking, that can be the cause. Also, if there's cartilage friction, so when your body produces fluid in response to something that it doesn't want to rub, so you get fluid for that reason. But things that we worry about are infections. So sometimes the swelling is not just due to the friction or because you banged it or because you have something going on, but because there's actually an infection going on. We also ask when your knee hurts. So if your knee hurts going downstairs, we talked about how that could be patellofemoral pain syndrome. If your knee hurts after you've been running 10 miles and it never hurts before 10 miles, then we think more of a tendonitis. We worry about stress fractures. We worry about swelling. There are certain things that you should not ignore. You should not ignore signs of infection. So if your knee is bright red, we worry about that. If you have a fever associated with it, if it's warm and tender, those are things that we want to get on top of pretty quickly because an infection can spread. Other things that can be a cause of knee pain are tumors. So this is not a common cause, but it is a dangerous cause. So people who have a lot of pain at night, we worry about that, and we usually get imaging a little bit earlier. And by imaging, I mean like an X-ray or an MRI. Or if you feel a growth, and it's not just like the fatty tissue, or it's not just swelling, it's actually you feel structural growth, that might be a sign that you have a tumor. And anything that doesn't go away. So I say pain is your body's way of saying something is wrong. Sometimes it's going to go away on its own. Sometimes it happened because you knocked it or you did something you shouldn't have done and you fix the problem and it goes away. No harm, no foul. If your pain doesn't go away, then your body is saying something is wrong. Either you're damaging something, you're continuously injuring something, or something is wearing away and we need to address it. So if something doesn't get better, please let somebody address that and help you figure out what it is. Other things we want to make sure we address is instability. Sometimes patients have a sensation of instability because the fluid in your knee turns off your quadricep muscle. So if you have fluid on your knee and it feels like your knee is giving way, it can be because your quad doesn't want to fire, and your quad is very important to knee structure. It could also be because you have a problem inside your knee. So the meniscus, if your meniscus has a tear, you can see how the bones have to hold on to the meniscus. And if the meniscus is sliding in between them, then you're going to slide. So that's something that we say you might have a meniscus tear. Also, you think about the ligaments, how they hold the bones together. If you're falling out because the ligament isn't holding them in place, you could have a ligament tear. That's usually due to trauma, which is associated with swelling, but certainly something to look at. And sometimes you can have a loose body. Sometimes you can tear off a piece of that cartilage, either your meniscus or a piece of bone or the articular cartilage, and that can catch. And so it's almost like you feel something catching in your knee and you have to shake it loose, or you have to, if it catches, it causes a really sharp pain. If you are worried about your knee giving way, that's a sign that you might cause another problem. You might fall down and cause a broken hip. You might fall down and tear a meniscus that isn't torn. So instability is something that we try to address early so that we don't come up with another problem later. I also worry about when people have pain with weight bearing. Sometimes it's just because you have a quick injury, but sometimes it's a sign of a bone problem. We worry about stress fractures, and I have patients come in who they don't even realize that they had a stress fracture. So they might be golfing and they haven't been walking that much, and then they go and walk 18 holes with their clubs. Or they haven't been running and they really want to get in shape and their gym is closed. So they start running more frequently than they do. this is usually a sign of a stress fracture. If you can't put weight through your leg because of the pain, then we worry about that. We need to take a closer look, because a stress fracture, if we ignore it, can progress to a full fracture. And I'm not a surgeon, and my colleagues who are surgeons understand I try to keep patients away from them if it's not in their best interest. But if you have a stress fracture that progresses to a full fracture, then you're probably going to be meeting one of my friendly surgeons for a slightly more aggressive treatment. And so we try to avoid that when we can. So what can a doctor do? What can a physician do? So first thing we do is listen to you. We already talked about you get to be the expert on you. Please let us know what's hurting you, when it's hurting you, what bothers you, what you're limited with, and what your goals are. If your goal is to be able to go, do a 5K, the next 5K that's available, that's useful. If your goal is to be able to walk to the mailbox, that's also very important, but we need to know what your goals are. Personally, when somebody comes in, I want to know what bothers them, because that helps me figure out their diagnosis. I'm going to do a physical exam. I'm going to get my hands on you. I'm going to check your strength. I'm going to check what's stable, and I'm going to do a few special tests, those provocative maneuvers to see if I can provoke your pain. And that's why when we think about the front, the side, the back, there's so many different structures in your knee. These special tests can be very useful. I like to get x-rays on patients because they show me the bones. X-rays only show bones. You can see here how with the x-ray, you can't see the meniscus, you can barely see the muscles and tendons, and you can't really see their structure, but it shows us, do you have a major fracture? Do you have malalignment? Do you have something wrong inside the bones, or are they not where they're supposed to be? That's very helpful. If, based on the physical exam and what you're telling me, if I want more imaging, sometimes I'll do a CAT scan, and sometimes I'll do an MRI. So an MRI is super helpful to look at the soft tissues, like the meniscus, the ligaments, the tendons. It'll show me that swelling or the bursa. A CAT scan is a little bit better for specifically bone. So if we're worried about a tumor or a stress fracture, that's what we look at. And then treatment. So we're never just going to say, okay, this is what's wrong. Bye. Thank you for coming in. Good luck. We're going to help you. So I love to try to get people to help themselves as much as possible. Patients are their best allies. So exercises are a great way to use your body better. Sometimes people want to work at home, and sometimes people want to work with somebody. So if they want to do home exercises, I try to give them a home exercise routine. If they want to work with a physical therapist, I try to hook them up with somebody who is a good fit for them, somebody who, based on their goals, can understand and meet them where they are. Also, the diagnosis is important. Medications. I don't like patients to be in pain, even though I said pain is your body's way of saying something is wrong. Once we're trying to fix something, we want to help you be more comfortable. Pain is not good for your body in general. It causes stress, it interferes with sleep, and it can actually set you back with the healing process. So once we know what's going on and we have a plan, usually I try to help the patient's pain and help them get better faster. This is very much up to the patient. If they don't want to take anything, we talk through that, but we can do anti-inflammatories, we can do muscle relaxants, we can do other things that can help the patient feel better faster, short of an injection or other options. There are other things we can do to help the knee pain to support it. We can offload a joint that's hurting, we can support a joint that's unstable, or we can try to avoid going into a position that tends to be unsafe for the knee. So that would be with bracing or taping or a knee sleeve. And of course, that's based on what the diagnosis is. So let's say you're in a bunch of pain and we're unable to really get you feeling better over the long term, or you need help with your pain in order to address your pain with physical therapy or bracing. Then we can talk about aspirations or injections. So that's an aspiration is when I draw fluid off the knee, and an injection is when I put something in. So that happens usually in the same procedure. If I put a needle into the knee, I can usually aspirate and inject at the same time. So it's not two separate procedures if we decide to do that. If you have fluid on your knee, sometimes I need to send it for analysis. That can show me if there is a rheumatologic cause, like a type of rheumatoid arthritis or a crystal that led to your knee swelling, or if there is some infection, I send it for Lyme disease. We often find that here in New York. That can be a helpful diagnostic tool. Also, I can inject a steroid, which is the most powerful anti-inflammatory. I tend to not do that right away, just because that isn't often the best first step, unless we are trying to save a trip of a lifetime or something like that. There's always a reason to do it, but that tends to not be my very first step, just because the steroid is not great for the knee cartilage, we're finding out. One injection is okay, but certainly we want to make sure we're doing that deliberately and not just doing it and having it wear off soon. Viscose supplementation, that's where we talk about you might have heard of the gel injection or hyaluronic acid, the rooster comb. There's a bunch of different brands, but essentially the goal is to replace the fluid on your knee. If we think that you have knee pain due to osteoarthritis, remember we talked about that friction. Once you've lost some cartilage, you get friction in your knee, and the fluid becomes less oily and slippery and letting the structures glide over themselves, and becomes more water-based or inflammatory. That inflammatory fluid actually is not as easy for your bones and your cartilage to glide over themselves, and so the viscose supplementation is like an oil change for your knee. So we draw off the inflammatory fluid and we put in this replacement fluid that helps you sort of glide over your knee. It helps with some of that stiffness. Other options can be what I call orthobiologics. So people have heard of regenerative medicine and stem cells. That's not what we're going into with this talk, but just be aware that when you do have some structural damage to your knee, sometimes we can help with other types of injections that can help your body heal itself. And that's with platelet-rich plasma or bone marrow aspirate concentrate, or you might have heard of adipose-derived stem cells. Those are all options for some specific diagnoses and for some specific patients. And if that doesn't work and you have a ligament that is torn, sometimes we have to replace or reconstruct that ligament. Sometimes if your bones are to the point where there is no cushion in between them, sometimes we have to talk about a joint replacement. Those are usually not our first step, but if all of these steps that we've done before don't help you and they're limiting your activities of daily living, they're getting in the way of you enjoying what you want to do, you don't get to go to the theater when it's open, you can't walk the golf course, these would be reasons that we would consider a joint replacement. Not that I'm saying that that's the first step, but I often will have that conversation with the patient if we're not able to help them in other ways. Okay, so that is my talk. How do I unshare? Stop share, I see.
You can just, stop share. There you go. Perfect. Thank you, Dr. Hrubes. Does anybody have any questions? Again, feel free to type it in the chat section, or you can just unmute yourself and ask it out loud.
Oh, hi, Stephanie Hammerman. Hi, doctor. I have a question. I know that our focus is on the knee, but I've had this plantar fasciosis for 2 years, and there's a small tear, like a 2 millimeter by 2 millimeter by 2 millimeter chronic interstitial tear, and now I have functional hallux limitus, where there's kind of pain under my metatarsal. I know the focus was the knee, but obviously there's some hip pain. Can you just make any, can you just make any about that? Is that something you treat or you specifically? I have to tell you, I've been to a million podiatrists, and I've also been to some surgeons, and I haven't had success.
So, Stephanie, you were cutting out a little bit, but I think I got the most of it. And I appreciate the question because it's never just one part of your body, right? I kind of alluded to it earlier, but especially the knee is connected directly to the hip and directly to the foot. So everything in particular to the lower extremities. So when we talk about plantar fasciosis, it sounds like you've already had an MRI. So usually when somebody comes in to see me for that, I do treat it, but we have to take the whole lower extremity into account. And the plantar fascia is connected to that is actually a continuation of your Achilles tendon, which is a continuation of your gastroc. And if you remember the back of the knee slide that I showed, that gastroc extends above the knee, and then your hamstrings extend below the knee. So actually, we have to look at the whole posterior chain in order to take the plantar fascia into account. And that's exactly what you were talking about with that hallux rigidus, because the plantar fascia is actually closely connected to your FHL tendon, which is the part that holds your toe in place. So all of that is sort of connected. So we have to take a look, and then depending on what's been done before, what has worked, what hasn't worked, and then we kind of can figure out what the next steps are.
Okay. Next question to the chat. Do you recommend seeing sports medicine first?
It really depends. So it depends on kind of what's bothering you. Some people have a great relationship with their primary care doctor. Some people have a physical. Some people actually have access to somebody at work that can be can triage the situation. I love it. I love seeing patients first because, of course, I want to help them right away. But sometimes you don't need to see a sports medicine doctor. I always say, if you're not sure, please come see me. I'm happy to see you. And I can send you to somebody who needs to help you, or sometimes we need to do more invasive, more higher diagnostic things. It's very hard for me to tell you what's wrong if I can't get my hands on you or visualize you. But at the same time, so if you have musculoskeletal pain, seeing a sports medicine doctor is never a bad choice. If you have a hard time getting in to see somebody and you have other options, then that might be an awesome option as well.
Okay, another question. Can you discuss how you decide which synthetic agent you will try to use for pain relief in the knee?
Oh, yes. So it's both a combination of what is wrong and what's going on at the time. So when you're talking about synthetic agents, you're talking specifically about like viscosupplementation or steroid? I'm going to say both. I'm going to talk about both.
I'm sorry, Dr. Gold, I just unmuted you.
So I'm just going to talk about it, and if you want to speak up and clarify the question, I am happy to talk about something more specific. But usually, so if synthetic agent, it depends on what the problem is. So if we're talking about somebody who has really bad knee pain, they can't walk on it, they're so sensitive and inflamed that they can't even tolerate physical therapy, or the brace hurts, and we've ruled out any of the bad things like infection or tumor or instability or like Lyme disease, these sorts of things, then a steroid can really help us get better faster. That would be the reason I would do that. Sometimes I have patients that they've been doing great with their knee rehab, and they had this amazing trip to Patagonia planned, and they tweaked their knee the week before. It's going to be very hard to get them perfect before they go. That would be a reason I would use maybe steroid as kind of a one-time thing. When we do know that they have this friction type pain, meniscus, when there's like meniscus pathology or wearing away, then the viscosupplementation, it depends on the patient's insurance. A lot of them are very similar molecular wise. If you talk to the different agents, the people that sell them, they will tell you what the difference is. But they can really help. Oh, I see Dr. Gold's follow-up question. The agents used to prolong the time before knee replacement. Okay, yeah. So the viscosupplementation can really help. People notice that it helps with stiffness, and that it helps with the decreased swelling. If that doesn't work, I love to use PRP if there's good space between the knee. So I like to use PRP, which is platelet-rich plasma, when people have a meniscus tear or they don't have necessarily the instability. Those structural things that the body has a hard time healing can respond well if we almost give the body a boost. And that's what I think of with the PRP. It's actually the exact opposite of a steroid. So a steroid is an anti-inflammatory, and platelet-rich plasma actually causes inflammation, which now we know is part of the body's healing cycle. Sometimes when PRP is not the right option is when we have some more advanced arthritis, and that's when we can do the bone marrow aspirate concentrate or the adipose-derived stem cells. But I do mention that specifically those, in order for those to work, you have to address the cause. So a lot of times the reason I see that those don't work to begin with is people think that it's kind of like a magic injection and it fixes everything, when in reality it doesn't fix the cause of the meniscus problem. Hopefully that helps.
Okay. How do you explain to patients who may not necessarily be symptomatic why their knees crack, click, or pop?
Yeah, so I would think of cracking and clicking and popping as a symptom, but sometimes it's not associated with pain. So usually that's a sign of some type of friction. So a lot of times they can get their kneecap to kind of pop or click, or they call it like Rice Krispies, where it's like a high-pitched kind of crunch. And I actually think that that's something that needs to be addressed. So that is usually a sign of some type of friction. Either the cartilage is kind of catching or it is producing some fluid. So even if it's not painful, that sound is something that needs to be assessed. Sometimes you can get catching and clicking of the bursa, the tendons over those bony prominences. And again, you don't want to ignore that because that is a sign that something is not moving well in your joint. So we need to address it before it becomes symptomatic or painful.
Okay. And what do you prefer for osteoarthritis?
Like for treatment? Oh, that's from Dr. Gold. Okay.
Dr. Gold. Yes, I'm sorry.
Okay, so usually for osteoarthritis, and it's very general. Every osteoarthritis case has so many different variables. It's hard to say what one thing I would recommend. But let's say that they have some mild to moderate osteoarthritis. If it's bone on bone, I tend to not recommend any orthobiologics. If it is just mild to moderate and they've had no injections ever, I will usually recommend viscosupplementation. Insurance pays for it and it can really help, and it helps with that friction. If that doesn't work or it doesn't work long enough, then we talk about PRP versus BMAC versus ASCs. I usually start with PRP because it's the cheapest. Insurance doesn't pay for any of those, but it can really it can help us know how much your body would respond. And then BMAC versus ASCs depends on the age. So usually younger people have similar amount of pluripotent cells in their bone marrow versus their adipose, whereas older people have more pluripotent cells in their adipose. So it depends on their age.
Okay, thank you. That's all the questions in the chat. Does anybody else have any other questions they wanted to ask out loud?
Yeah, hi. I wanted to ask for specifically for an ankle, if there's a particular physical therapist known that he just specializes in that. Like I've had this 2-year fasciosis and the functional products limited. I really need someone super specialized in that who really knows it because I've been through the mill, and so maybe a particular physical therapist specialized in that.
Yeah, they're definitely, I would say that's a good thing to start with. I would say it would depend on where you are. So maybe Jen can work with you individually to figure out where your location is. And then we can kind of address that and see if we can help set you up with somebody who can functionally.
Okay, so right off the bat, if I told you that I was on the west side, West 70 and Riverside, does anybody jump to mind?
I'm going to have Jen reach out to you individually.
Okay.
Yes, Stephanie, I can follow up with you after and send some recommendations.
Okay, no problem. No problem.
And I saw some pop up with the chat about Voltaren gel. Yes, that's along the lines of anti-inflammatory. It depends on where in the knee the pain is. If it's like if there's a ton of fluid, the Voltaren gel tends to not be as effective, but especially those enthesopathies, the parts where the tendon meets the bone, or the bursopathies, those can really respond well to just a topical gel. So when we say Voltaren gel, that's the anti-inflammatory pill that's been crushed up and put into a cream. That used to be, you had to have a doctor's prescription for that in the United States, and now it's over the counter. So you can pick it up at Walgreens, and it's something that you can try. There is some systemic absorption, we say about 10%. So you do have to use caution if you have a history of kidney or liver problems. Make sure that you don't have a contraindication.
Okay.
Like you mentioned about skin, when you hear the Rice Krispies, you're hearing the Rice Krispies as you're rotating your ankle to try to dorsiflex it, like you're trying to get more dorsiflexion. Do you advocate that patients mobilize with bands, like to try to pull the fib, if they know they think their fibula is too forward, like to try to use like a band and pull the fibula, like, back a little bit?
Yeah, I caution patients against self-mobilization that's not being directed by a physical therapist, just because sometimes they can cause an instability or they can actually overcorrect. So that can actually lead to other problems. But the ankle in particular does tend to stiffen up. So trying to keep it mobile, if you're not in the direction of a physical therapist or a physician, just the most I would do would be active range of motion until you know that there's no instability.
Okay. I've seen like a million people, and it's just they give you the exercises, that are online, and I don't have any instability. I just don't have this mobility, and I just don't know how to get it.
I think we're going to have to talk offline, Stephanie.
Okay. Sorry.
Oh, you're fine. I just think we're kind of going down. I want to make sure we get to everything that anyone else has.
Great. We have another question. I had a torn meniscus over 10 years ago. Recently, the back of my knee is very stiff. I'm trying to figure out what type of doctor to see for foot harassment.
Oh, come see me. It's totally.
Mm-hmm.
Yeah.
I will also, I'm going to be sending our scheduling phone number and all of our information as well after the talk.
But if I'm not in a location that's close to you, I can help set up somebody that would be a good fit for you. The thing about the fact that you would know that you had a meniscus tear 10 years ago, the question is, what does your knee look like now? So yeah, especially if you have the back of your knee, remember we showed that picture with all those tendons, the ligaments, and there can also be some swelling. So the question is, why do you have that back of the knee stiffness? And we usually need to make sure there's not a structural cause, because when you lose full extension of your knee, we worry about the implications for your hip and your ankle. So we do want to try to get on top of that pretty quickly. So I would definitely recommend getting to work. We can figure it out.
Okay. Another question, does walking with knee pain cause damage?
Oh, yeah. Sometimes it does. Sometimes it doesn't, but I would err on the side of more often it does. Because remember, I mentioned pain is kind of your body's way of saying something is wrong. What if you're walking through a partially torn meniscus and you finish the tear? What if you're walking through a tendonitis that would heal if you protected it, but instead, if you continue insulting it, it actually partially tears or continues to degenerate? I always worry about stress fractures. People who run through pain, I always worry about the bony problem that could get worse. I always try to keep people from causing more damage. And one thing that we think about, especially when you have knee pain, if it hurts when you're walking, how are you compensating? And how does that affect other joints? So with knee pain, a lot of times if people keep walking, they end up with pain because they don't want to bear weight as often, or they have to kind of twist their knee a little bit to offload that pain. They end up with like IT band pain or pes anserine bursitis, other types of pain. I call those compensatory behaviors. So it depends on the diagnosis, truly, to answer your question accurately. But I always, as a physician, because I probably tend to see the things that don't go well when you keep weight bearing, I certainly would recommend making sure that you're not walking through something you shouldn't.
Okay, thank you.
Can I say one other thing, Jen?
Yeah, sure.
If you're in a place where let's say you're on vacation and you have knee pain and you're like, well, I don't want to stay in my hotel for 10 days. obviously people aren't on vacation right now, but if you're somewhere, then I would think about like using crutches or a cane or something to offload that knee to make sure you don't damage it further. Okay, that's it.
Okay, great. Does anybody else have any questions? If anything else comes up, you could always email me afterwards, and I will work with Dr. Rubish on getting all of your questions answered. But as previously mentioned, Dr. Rubish, our sports medicine doctor, she currently sees patients out in our offices in Manhattan at our Gramercy location, and also Murray Hill. It was temporarily closed due to the pandemic, but it will be opening in a couple weeks, and also in Harrison in Westchester County. We're currently seeing patients in the office, but we are also still doing televisits for those that aren't comfortable with coming into the offices yet. So if anybody has any questions, needs to schedule an appointment, or needs anything at all from Rossman, I did send our scheduling phone number in the chat section. For those that can't see that, that's 646-891-5540. But I will send a follow-up email with, again, that information. I'll also send the recording of Dr. Rubish's lecture from today. If you'd like to share the information with anybody, or you can forward the link along. And again, if anything comes to mind, and if you have any additional questions, please feel free to email me afterwards, and I will work with you to get those questions answered. But thanks again, everybody, for joining us, and I hope everybody continues to stay safe. Thanks, Dr. Rubish.